Take a population of healthy adult volunteers, get them to inhale volatile agent until they reach a steady state in tidal concentration. Then inflict a surgical stimulus, which is a 1 centimetre wide, 1 centimetre deep wound. The concentration at which 50% of that group of people move in response to the stimulus and 50% remain still is 1 Mach. The Mach value is an indication of the potency of any given inhalational anaesthetic agent. So for sevoflurane, 1 Mach is achieved at 2% in tidal concentration, and for desflurane, 1 Mach is achieved at 6% in tidal concentration. This means that sevoflurane is 3 times as potent as desflurane. Some things change the Mach value. Older people require less anaesthetic agent, so the Mach value for them is reduced. People who are acutely intoxicated with alcohol and with other sedative drugs, including opioids and benzodiazepines that we sometimes give in anaesthesia, have a reduced volatile anaesthetic agent requirement, so 1 Mach is lower. And dementia causes a reduction in the amount of anaesthetic you need to give to achieve 1 Mach. Some things increase the amount of anaesthesia you need to give to achieve surgical anaesthesia. So chronic alcohol abuse causes Mach to increase. Stimulants like cocaine and ephedrine, intoxication of them causes Mach to increase. And chronic abuse with opioids also causes Mach to increase. 3 key concepts. First, partial pressure. In a mixture of gases, each individual gas exerts a pressure that contributes to the total pressure in the mixture. Each individual contribution is called the partial pressure, and it's the arterial partial pressure of a volatile agent that determines its effect on the brain. Second concept, blood gas solubility. The blood gas solubility coefficient determines the solubility of a gas in blood. Agents with higher coefficients are soluble, so it takes longer for partial pressure to rise and fall, resulting in slower onset and offset. Desflurane, sevoflurane and nitrous oxide all have low blood gas solubility coefficients. They achieve high partial pressures rapidly, and so depth of anaesthesia can be changed quickly. Finally, oil gas solubility. The oil gas solubility coefficient expresses the solubility of a gas in fat. Drugs with a high coefficient are absorbed by body fat, so at the end of anaesthesia, elimination and emergence take longer. Desflurane and nitrous oxide have low coefficients and minimal uptake into fat stores, so emergence is rapid, even after prolonged anaesthesia. Sevoflurane is moderately soluble, and emergence is much slower compared to desflurane after prolonged exposure. Volatile agents are depressant. They cause central nervous system depression, loss of consciousness, loss of spinal reflexes in response to painful stimuli. They cause cardiovascular system depression. Hypotension can be significant, particularly if the patient's taking antihypertensive drugs or if they have a shock state, sepsis, hemorrhage, cardiac failure. The hypotension is mediated mainly by a reduction in systemic vascular resistance, but there also is some reduction in myocardial contractility also. They're respiratory depressants. They cause a reduction in minute volume, tidal volumes reduced, respiratory rates often increased, but not quite enough to compensate for the reduction in tidal volume. The result is a rise in arterial CO2. As well as that, they cause depression of airway reflexes. So even if a patient is breathing, they may obstruct and come to harm as a result of that. They cause skeletal muscle relaxation and potentiate muscle relaxants, and they cause relaxation of uterine muscle above 0.5 Mach concentrations. So they should be used cautiously in women at caesarean section or say, retained placenta after delivery, as they can prevent the uterus contracting and impair hemostasis. Along with succinylmethonium, all volatile agents are potential trigger agents for malignant hyperthermia. This is a syndrome caused by a genetic abnormality of the ryanodine receptor. When susceptible individuals are exposed to trigger agents, there's a rapid rise in intracellular calcium, causing muscle rigidity, uncontrolled rise in temperature with associated rises in PaCO2 and metabolic acidosis. This syndrome is fatal if left untreated by cooling and administration of a therapeutic agent called dantrolene. Although they have more in common than not, there are some reasons to choose one volatile agent over another. Sevoflurane is the most common agent in modern use. It's a potent agent. It's got a MAC value of 2%. It's non-irritant, so you can use it for inhalational induction of anaesthesia. Patients won't cough. It's got a low blood gas solubility, so you can change the depth of anaesthesia quickly. And it's got a medium oil gas solubility, so it's moderately soluble in lipid. It does tend to accumulate if you give it for a long time, and emergence can be slow after prolonged surgery. Desflurane is the only other volatile agent that is used really in modern anaesthesia. It's 3 times less potent than sevoflurane, so it's got a MAC of 6% versus 2%. It's irritant if you breathe it when you're conscious, so you can't use it for inhalational induction. People just start coughing. And even if you've given an IV induction, if you introduce it too quickly in spontaneously breathing patients, they will cough or develop laryngospasm. It's got a very low blood gas solubility, so you can change depth quickly and patients come round very quickly. And additionally, it's got a low oil gas solubility, so even after prolonged anaesthesia, it doesn't really accumulate in lipid and patients come round very quickly. However, the major downside, it's a very potent greenhouse gas. Using 1 bottle of desflurane is the equivalent of burning 440 kilograms of coal. It's considerably worse than sevoflurane for this, and also it takes 14 years to break down in the atmosphere compared to a year for sevoflurane. So it's really questionable whether its occasional advantage in waking up people slightly quicker is worth the environmental side effects. Nitrous oxide is an analgesic and anaesthetic gas. It's used most commonly in a 50-50 mixture with oxygen called Entonox. Ambulance crews use it to deliver inhaled field analgesia, and it's used commonly as a labour analgesic. Its use in anaesthesia is limited by its low potency. You need to inhale about 70% nitrous oxide before you lose consciousness, and if you want surgical anaesthesia, you need to administer a hypoxic mixture, so it's not useful in that sense. However, it can be used as a co-agent with volatile anaesthetics. It causes minimal cardiovascular and respiratory depression, and so using it can limit the amount of volatile you use and so limit cardiovascular and respiratory depression associated with the volatile agents. It's got a very low blood gas solubility, so you can change depth very quickly with it, and has a very low oil gas solubility, so it doesn't really accumulate in fatty tissues at all, so you can use it for prolonged periods and it doesn't accumulate, so you wake up very quickly when you switch it off. Side effects: it causes nausea commonly. It causes expansion of air-containing spaces, so if a patient has a pneumothorax, you can make the pneumothorax worse. If a patient has a gas bubble inserted during eye surgery, it can expand the gas bubble and be potentially catastrophic for the eye surgery. It's used for prolonged periods of time. This usually happens in people who are addicted. It can cause bone marrow suppression, megaloblastic anemia in particular. So it's not used very often, nitrous oxide, anymore, and it's a potent greenhouse gas also, so probably for that reason at all we should use it pretty minimally now.